And welcome back, everyone, to our first ever virtual conference for the Kids Brain Health Network. I'm Dr. Brian Goldman, your host and guide for this 4-day event. I also host the CBC radio program White Coat Black Art and the CBC podcast The Dose. Hope you all had a chance during the break to try our networking sessions at Gathered Town. You'll have plenty of opportunities in and around the sessions in the next few days. If you haven't, you will at the end of our next discussion to wind down the day with some networking and private chatting in the Gathered Town virtual rooms. And we hope you'll partake in those because they're a lot of fun and they're really great for interaction. You can interact one-on-one with our poster presenters as they discuss their latest research and findings at the poster sessions. All that, of course, will follow my end-of-day reflections coming up after the next panel, so don't miss that. But first, let's introduce our next group of experts who will focus on service delivery and research during COVID-19. We know everything's changed, and we want to know how those have been affected by the pandemic and how we define our new normal. This session is sponsored by our bronze sponsor, the Ontario Centre of Excellence for Child and Youth Mental Health, and we welcome to this panel our moderator, Dr. James Reynolds, Chief Scientific Officer of Kids Brain Health Network. He's the Associate Dean of Graduate Studies and Professor in the Department of Biomedical and Molecular Sciences at the Center for Neuroscience Studies at Queen's University, who will introduce this session's speakers. James, you have a fantastic lineup coming up, don't you?
Absolutely, and thanks very much, Brian, for that introduction, and welcome back, everyone, for this session, which I hope will be informative and inspiring. But we're going to talk about some difficult and hard challenges and problems. I'm going to first introduce the members of the panel before I say just a few words to put things in context. So with us this afternoon will be Tracy Moisen, a marketing and communications leader at Adopt for Life, Ontario's Adoptive Parents Association. We also have Dr. Jessica Bryan, clinical investigator with Holland Bloorview Kids Rehabilitation Hospital. Dr. Chaya Kulkarni, director of infant mental health promotion at the Hospital for Sick Children. Brian Katz, vice president for Child and Youth Services at the Center for the Child Development. And Alex Munter, President and Chief Executive Officer at the Children's Hospital of Eastern Ontario. So, in the first week of March 2020, I was at a large national conference in Toronto on infant mental health and early brain development. We had over 450 delegates at that conference. Can anybody remember even when that was possible to do? But we all know what happened. Well, actually, thinking back, I have to chuckle. There was a lot of people from public health at that conference, and the idea of physical distancing was don't shake hands. Well, we all know what happened a couple of weeks later. All of our worlds came crashing to a halt. Everything stopped. At the university, we shut down all in-person classes. We sent students home. And I can only characterize the ensuing days and weeks as chaos and confusion. It seemed like daily we were making up a new practice and or policy. And pivoting to an online format for classes and exams that had never been contemplated, let alone put into widespread action. Students were sent home, but for those who were involved in person training, medical students, nurses, occupational therapists, physiotherapists, they were all sent home, or their clinical training was canceled, or their placements and practicums were put on hold. This threatened, for many of them, threatened their ability to complete their degrees and graduate, move on with their careers. Needless to say, this created an enormous amount of anxiety amongst these students who were suddenly saw their financial support at risk, their professional development, their ability to complete their programs, graduate, and move on with their lives. All of these things seemed to be in jeopardy. And this created an enormous amount of anxiety in those students. It was quite widespread. The incidence of mental health issues jumped enormously, and that shouldn't be a surprise to anybody. And the reason I tell this, put this in context, is the university is a large, relatively, actually most of us are well-funded institutions with a lot of people and resources to put towards adapting to the new situation and the challenges and issues that faced us. Now let's think about kids. And in particular, let's think about kids in a family, kids with a neurodevelopmental disability and their families, and what they faced in trying to adapt to the sudden removal of services and supports, to being socially isolated, to being unable to contact peer support networks the way they had previously. Children who are unable to go to school, unable to have those important social interactions on a daily basis that they come to depend on. What about them? They're a very vulnerable population, and many of us would argue we're the forgotten population in the COVID-19 pandemic. And the challenges that they've faced and what's happened with those kids and those families is going to be the topic of our discussion this afternoon. You'll hear how across different service sectors and programs, we've all tried to adapt. But I wanted to start off by inviting Tracy Moisen to lead off with some perspective on what it was to be a family facing this crisis. Tracy.
Thanks, James. So in some ways, James just really outlined what our experience was. In addition to being a Doc for Life, I'm here primarily as a parent. I'm a parent to 3 neurodiverse children who are chronologically 9, 15, and 18. I'm not sure that those are the correct slides. So I'll keep going while that sorts out. I mentioned my children are 9, 15, and 18. And fetal alcohol spectrum disorder, or FASD, is very much a part of our everyday. And along with it comes related challenges from anxiety, sensory processing disorders, intellectual disabilities, and general mental health. And as an adoptive family, our kids also have live with the lasting impact of early developmental trauma and the impacts of early disrupted attachments. I always feel it's important to say in these cases, they're also really funny, creative, caring, expressive individuals who are very okay and have given me permission to share some of their stories. As James said, you think back to March. For us, 241 days ago, schools closed, occupational therapists closed, physiotherapists closed, speech therapists closed. Overnight, the existing network of support and structure that we had built for our kids and for us really crumbled. And we immediately started to see the impact of that loss of continuity, that loss of structure, school and community connections, social supports, therapeutic supports. And while that immediate loss was felt, as things dragged on over weeks and months, the impact got worse for us. We saw regression in behaviors and abilities where we had seen tremendous growth over the years. We really, in many cases, went back to where we had started. We saw significant increases in anxiety. We saw signs of depression in at least 2 of our children. General mental health, dangerous, explosive behaviors were escalating, and we were experiencing violence in our home. And we knew that we were trying to figure out a new normal that nobody else around us had answers to either, and that we really just had to start over. And so I remember vividly being on a Zoom call, because we lived on Zoom for months, being on a Zoom call, and it was 10:30 at night with our FASD worker and a therapist who has worked with our family for several years. And we were all just trying to brainstorm everything we could think of. What could we come up with? What could work? Creative new solutions. And I realized in that moment, though, that they didn't have the answers either, that we were looking for others who had the answers, who were all trying to figure it out in real time. And so for me, I very consciously chose to say yes to everything we could come up with and know that we were going to have to adapt in real time, because that's what our kids needed. We were desperate for help, and we just had to figure out what that would look like. And so it became OT sessions that were delivered over a private, secure portal, leveraging sensory equipment we already had in our home. It became Zoom sessions over counselors that became much more shorter and more frequent in our home. It was a virtual youth groups hosted by the Fetal Alcohol Resource Program that our kids could connect into. CHIO offered an emergency respite program that, while in our case ended up not being a great fit, it gave us the breathing room to figure out what a respite solution needed to look like and how to create it. We, in our case, expanded our bubble. We very consciously chose that we needed to have more respite in place for our kids and for ourselves. And so in our case, that meant hiring in-home support. And taking that risk that, while technically we were probably not within the range or the realm of our COVID requirements, it was what we needed to do for our kids. We navigated endless referrals for e-mental health and telemental health, moving back and forth between CHIO, Sick Kids in Toronto, CPRI, and finally landing with video consults from the trauma team with sick kids that became a lifesaver for us. Over time, we've built back in some important face-to-face connections. I mentioned my son does weekly counseling sessions that happen in a park while he and his counselor play football, which also addresses some of the sensory input needs that he has. We have a great team who's figured out how to do equine therapy in a socially distanced, modified setting that can work. And we're still adapting. We're still figuring out what works for them, what works for us, and how to make things work as COVID shifts. We've learned a few things that I'd like to share with all of you as we talk about solutions this week. Virtual can't be the only answer. So while there are incredible opportunities for innovation, for kids like ours and many like them, more internet time, more internet access actually becomes a safety issue and is something that can be hard for families to accommodate. My youngest son is an example of OT over video and physiotherapy over video. He needs much more direct engagement to be able to keep him focused long enough to benefit from the skills and strategies that we are working on. In some ways, though, virtual was better than it was before. My children had much more direct, often frequent access with their FASD worker than we probably would have even tried to create before COVID. And that was a really good thing for them. I think, as someone mentioned this morning, just the simple reality of taking out the commuting time to and from appointments and specialists and therapies simplified things in many ways. I'd ask you all to remember a couple of things as we talk about solutions this week, though. The whole theme of the conference around building connections and imagining new connections. I'm not going to be able to say this nearly as eloquently as Dr. Blackstock did this morning, but equity matters. We were able to rebuild new networks and new supports and figure out new solutions, in large part because we had the financial means and the job flexibility. My apologies. And the access to technology to do so. And I'm really conscious of the privilege that is inherent in that, and that even with those, it still often felt impossible. And to that end, I think solutions have to be much more accessible. The average family needs to be able to find and access the services that we're talking about. And for families who don't have reliable access to technology or internet or online connected services, that's challenging. And lastly, I would just say relationships and connection matter probably more so now than even they did before. I mentioned, my son's counseling sessions that are happening in tossing a football around. Those are the results of a counselor who really understood that online virtual sessions were creating a risk and was determined to find a solution that worked. Our FASD worker called my son every day for weeks this summer for a 5-minute check-in. And she figured out how to make that work in her day so that he knew that she was as invested as he was, that he was okay. We're okay, and we have rebuilt our network, and it is still shaky. I consider ourselves to be really well supported and really able to find and create solutions. And often as COVID keeps shifting and as things keep shifting, it still feels like we're often moving from crisis to crisis. And I know that we are not alone. I mentioned I'm here as a parent, but I work with Adopt for Life, who provides peer support to adoptive families in Ontario. And we are hearing every day from families who are experiencing many of the same challenges we are, and who never ever thought they'd find themselves in a place where they would be thinking about or having to manage through adoption disruptions or placement disruptions, and they are. And so I'm thrilled with the conversations that we're having this week, because families like ours and like mine need more help. James, I can turn back to you.
Thanks very much, Tracy, for sharing that with us. We have to be reminded about why we're here, and the families and the kids that we all do this work for. So I should have reminded you, I should have informed you at the beginning, which I didn't, that you can access Q&A through the Slido link that you should all have. Please, we will have this time for discussion after all the panelists have given a presentation. So if you put your questions in the Q&A on Slido, I'll be monitoring that, and we'll bring those questions forward after the panel have made their presentations and as part of our general discussion. So next I'm going to call on Dr. Jessica Bryan to address the delegates.
Thank you, James, and thank you so much, Tracy, for sharing your family's experience. I think it really is clear that everyone's had to adapt and be flexible, and families probably more than anyone. So I think your story is really important for everyone to hear. So I'm Jessica Bryan. I'm a psychologist at Holland Bloorview. I'm just sort of going to be sharing today how our team pivoted into this virtual space that we're all enjoying now. So I have a large team, and none of this could happen without them. As you all know, it really does take a village to get this work done. So I'm really going to be talking today within the context of the social ABCs, which is a parent-mediated intervention that was developed for toddlers who have autism, autism spectrum disorder, or sort of related social communication challenges. It's play-based, routines-based, makes use of the principles of applied behavior analysis and within a developmental framework. And we really target shared enjoyment and intentional vocal communication. This intervention, we've been working on it for several years now, and the sort of standard model is a 12-week model that involves working with families in their homes, providing live coaching. So the evidence regarding sort of the efficacy or effectiveness of the standard model comes from 3 studies that we've completed, and what we show is that after 12 weeks of parent coaching, we see gains in children's communication, social attention, shared smiling with their primary caregivers. We see that parents learn the skills. Sorry, I'm getting a message here.
I need that presentation to roll these.
We see that parents learn the skills that we teach them, and we found that in a large community extension, this intervention is both feasible and effective. And so we really feel excited about the idea of getting in as early as possible, ideally pre-diagnosis, when we sort of see first signs of social communication challenges. And sort of premised or based on this research that we've developed, we were really motivated to move this intervention into sort of integrated into a clinical care pathway. We really wanted to find ways to increase access or scale up the intervention. And we had sort of an eventual goal of moving into the virtual space, which came faster than we had expected. So our first adaptation really was to develop a group model of the social ABCs so that more families could access this intervention more quickly. So in the group model, we work with families where we have sort of didactic components of the learning that take place in a group context. And then we still have one-to-one parent-child coaching sessions that were taking place in the clinic. Everything's recorded, and we ask parents to complete questionnaires before and after the intervention. And for a while, we've been doing this model both in research and in clinical care. And I'll talk a little bit about what we're seeing from the research perspective in our group model. So this is the in-person 6-week group model. We have worked with 45 families from a sort of range of ethnic and educational backgrounds. And what we found when we worked with these families for 6 weeks was some really nice, significant gains before we start intervention until 6 weeks later, in terms of parents using the strategies that we teach them and sort of toddler responsiveness or responsivity to their parents' language opportunities. So when parents say something, how often do the children respond? We're seeing nice, significant gains in both of those, and a relationship between the two. So parents learning the skills is impacting the child's development. We're also, we're seeing, parents were reporting feeling self-efficacious, feeling reduced stress, empowerment, and they're describing sort of reduced ASD symptoms in their babies, and reporting increased words understood and spoken. So we're feeling very optimistic that the group model has potential and allows us to see more families more quickly. And then COVID struck. And I think, we all know what happened next, but like everybody, we sort of had to pause for a moment. We had to regroup, think, plan. We definitely had to pivot like everybody else, and the way Tracy described. I'm going to talk about 2 main pivots, and ultimately we decided to dive back in and keep doing what we felt so positive about. So we changed our group model a little bit, and we kind of moved those first 3 segments into the virtual space. So now we were doing didactic sessions over Zoom. We were doing one-to-one coaching over Zoom. So now families are back in their homes and our coaches are on the other side of a computer screen and still recording sessions to sort of monitor change. So what happens when we go virtual? We've now actually worked with 39 families. So our rate of working with families actually has increased quite a lot. We've been able to be, I guess, more nimble. And what we find is if you think about sort of how parents are parents still learning the strategies at the same pace that they were in person? The answer is yes. So using the virtual model, there doesn't seem to be any sort of loss in terms of parents' ability to learn the skills that we're teaching them now face to face, but with a computer between us and lots of space between us. And on all of the child and sort of parent measures that we have, we're seeing gains and change that are almost identical to what this looked like in person. So, and we're hearing really positive things from our families, which is the most important for us. So just thinking about building up and building out, our first pivot really was kind of at a micro level where we worked with our internal team, some of whom are not in the same city as one another or the same province, but with the virtual space, we actually were able to get together a little bit more easily and with our research families and providing this program as well through clinical care. And then we also sort of had all these evolving partnerships and promises that we had made and groups that we had started training before everything got shut down. So we now have made a second pivot where we're providing virtual training to other, to community providers, research collaborators, both across Canada and globally, using a lot of the principles that we learned from working individually with the families in terms of pivoting. So I've sort of identified the steps and thinking about the facilitators that got us there. We did have to make a decision to dive in that really took lots of planning, but a really supportive, motivated, enthusiastic, and flexible team. We had to do some of the paperwork things that take time and energy in terms of ethics and agreements. And again, our institutions were very quick in terms of responding to those requests. We all, as all of us here have had to do, we learned a lot of new technology and how to get things going over the virtual space. And really the most important facilitator was, from the family perspective, was really kind of building trust, building that confidence, as Tracy talked about, sort of that willingness to take a shot and see how things are going, and be willing to adapt and listen and learn to address each family's individual needs. And then that was really paralleled as we've worked with different training groups in terms of adapting our training approaches to what each community and research partner has been, what their needs have been and what they've been able to do. So ultimately we've rolled out the program and we've reflected and we've made some changes, but ultimately sort of at the program level, we've shown that using the virtual space, efficacy and fidelity of the program can be maintained. We can increase access to this program, which ultimately means that more families are supported, which was always our long-term goal. And now we're just in a position to take that learning and amplify it by building up and building out with training community providers, global research partners. And we're really excited with how well it's going. Again, that flexibility that Tracy mentioned and the adaptability has been just a saving grace in terms of my amazing team and all the partnerships that we've developed over the past few months. And really, I just wanted to thank our my research team, the toddlers and the families who participated, our collaborators, partners, our funders, of course, and this is our amazing virtual team. So thank you very much.
To moving services and making them as accessible as possible. So next, I'm going to ask Chaya Kulkarni, Director of the Infant Mental Health Promotion Group at the Hospital for Sick Children, to talk about their programs. You're muted, Chaya.
Okay, yep, that's great, thanks. Okay, so I just want to give you a little bit of background about our program. It's focused on children 0 to 6. We're evaluating a model for providing developmental support plans for children who may show any kind of vulnerability for development between the ages of birth and 6. And so this project right now that I'm going to share with you is being piloted in a number of Indigenous communities across the country. And, you know, we definitely could not do this with all of our partners who are involved with us. Just one second, because I need to bring up my own slides for a minute. So our overall objectives with this program, we want to be able to train people. We want to build capacity in communities. We want to be able to ensure that we're using a culturally sensitive model as well in the work that we're doing with families. And we want to be able to evaluate whether or not practitioners feel like they are learning more about infant and early mental health that they can actually embed in their practice. But we also want to know if this process actually leads to better outcomes for young children. And we want to do all of this within a culturally respectful and sensitive framework in terms of our partners in Indigenous communities. So the rationale for doing this, using this approach, was that we were running into many agencies supporting vulnerable children who may or may not have had a diagnosis, but may have shown some kind of concern or reason to be concerned about their development. And far too often, these little ones, because remember, we're focused on 0 to 6, these little ones would sit on waiting lists. Well, that was actually if they were lucky. Often people didn't even know what to do. So they would be observing a young child and they'd know that something wasn't what they expected it to be, but they didn't really know what to do with that. For those who did sort of say, yeah, okay, I know that something's definitely not quite the way it should be, where do you make a referral? But if you're lucky enough to know where to make the referral, quite often children literally sit for months and sometimes years on a waiting list for service. And that's if you're lucky enough to be in a community where there is service. So many kids will go with nothing until they hit the school system. So this program was really designed to give any practitioner a way to be able to understand a child's vulnerability and then be able to provide a developmental support plan that is really responsive to the child's developmental needs. And all of this done in a framework that is extremely parent-friendly. The goal is the child's goal. It isn't about judging parents at all. It's really focused on what does this child need and what are daily activities that can be used to support this child's development. So 2 key principles. One was that the focus was really on building relationships. And the second was that we wanted to ensure an Indigenous lens to everything that we were doing. So we did have quite a process that was and continues to be collaborative. And we have established inclusion criteria, we've created tools, and there's a great deal of thought given to organizational function and what can actually fit and work within the organizations that are in a community. So to some degree, it looks a little bit different in every community that we're working in because we're working with the strengths of that particular community and adjusting and adapting the program. And we really saw this during, once the pandemic put us all into lockdown. And it was interesting because it wasn't about us teaching our partners. We were learning a great deal from our partners because they were pivoting very quickly. They were doing, front porch home visits. They were doing the phone calls. They were doing the video conferences. So recently somebody asked me if we could do a workshop on engaging families virtually. And I said, yeah, sure, we can do that. We'll just get a whole bunch of people from all of our sites onto the screen, and they're going to tell you how they do this because they've actually become very expert. So I would say 4 out of our 6 sites, and they range from, well, actually, when I think about it now, they're mostly rural sites, and they are all fully engaged with their families. They have kept the project going. And our basic hypothesis is that using relationships at every single level of this work, and that includes our relationship with the advisory councils, with the staff in the program, with any of the elders involved, with really anybody, is pivotal. We really believe that if we can share what we know from science with the experience that practitioners and communities bring to the project, we can actually make a difference for children by doing developmental screens early, by providing developmental support plans, and really and truly seeing parents as the greatest gift that a child has, and building on not just the strengths of the child, but also the strengths of the parent, caregivers, and families. So we engage parents in doing a developmental screen, an ages and stages questionnaire. For time 1, that's business as usual, even if there are concerns. But after time 2, every child receives what we call a Nurturing the Seed developmental support plan. And that cycle repeats itself 4 times over the course of 1 year. We have some families who are who have finished their 4th time and are now saying to us, can we stay a bit longer? So we're including families for longer. This is what the plan looks like when it's given to families. It's in the voice of the child. We start with the child's strength, what they can already do. Then there's a goal for the child. And then we identify what are the things that, what can you do to help me reach my goal? Is the child saying, here's what you can do to help me do this thing you want me to do. And then we give the parents a little bit of the science and why this is important. So we've been looking at the data, and Dr. Reynolds' students have been doing the analysis on all of this data. And initially what we see is that there's a need out there. I mean, I'm seeing kids in some of these communities, 7-year-olds, who are having difficulty with speech, and nobody is doing any work with them. And that's just, it's not an acceptable situation, I don't think. What we also see across all domains is that from time 1 to time 2, there's an improvement. So even though we're not introducing the developmental support plan, just doing the developmental screen and having a conversation with parents about their development gets families thinking, what should I be expecting from my toddler? What could I be doing with my little one to support their development? So what we saw was that, in fact, there's a significant improvement in fine motor from screen 1 to screen 2, because I think a lot of families just may not be aware that we need to exercise these little muscles and give children a chance to practice. And that's the thing with early mental health, is that for many kids, it really is about the opportunity to practice skills that they just may not be given for any number of reasons. I was going to do a case study, but I think I'm probably running out of time, so I'll just capture this to say we recently took a look at 4 little boys who are with 1 foster parent. All have had pretty traumatic histories, potential diagnosis of FASD, and in all cases, except for 1, those little guys are all doing, they're all improving. Right? And you've got a foster mom who's really committed. She's fostered over 200 kids, really committed. And she's been putting this plan in place since 2019. And we're seeing that when she's working with the childcare and herself, we see improvement. We've got 1 little guy who's really struggling, and he goes to school, and we've just learned he's been kicked out of school, essentially. So we're now putting a plan in place. We're going to get the teachers at the school to do the developmental screen. We're going to put a classroom plan together for them and see if that makes a difference. But otherwise, for this little guy, that would typically be it. He'd be kicked out of school, and that's it. Nobody was coming to her with any kind of a plan. So where we are now is that right now, Nurturing the Seed is basically a tool people use on their computers. And as much as we're a technical world these days, people struggle, especially practitioners who work with families, because they don't sit behind computers. So even though we're asking them to copy from one Word document to another Word document, it is a bit of a struggle for them. So we're now in the process with the funding from Anishinaabe Nation to create an application, an app, I guess it's called, for Nurturing the Seed. We're working with an agency to develop the look and feel of this particular application so that people will go in, they'll create their plan, and they can email it right away to the family or any other practitioner. I'm just sharing some of the screenshots with you. It's quite a process. I've never done anything like this before in my life. We've been through several iterations of the images. We started out with just a child, and then we told the illustrator, well, no, all of our work is relationship-based, so you've got to have the relationship in the image. So this is where we have landed. And we're having a really interesting dialogue with our partners in Indigenous communities about the use of animals versus more people-like images. And that is an interesting discussion that we're in the midst of. So The project will continue until 2022. We're bringing on more sites actually than we were supposed to have. We have sites calling us, communities calling us up to be part of this. So we should have quite a story to share, I think, in about a year when we've got more data. And the only other thing as a result of COVID that has been a challenge is data collection. And, you know, Jessica, I don't know what that's been like for you guys, but we can't go into our communities to gather our data. So we're now building capacity in the community and identifying data entry folks in the community who can go in and enter that data, because we have a commitment to not take data out of the community. So we're just working through that process right now as well. So thank you very much.
Thanks very much. Now, remind everyone, we will have time for discussion after our final presentation. So if you have questions you'd like to address to the panel, please put them into the Q&A on the Slido link. I'll be monitoring that, and I'll bring your questions forward to the panel after our presentations. So next, I'd like to call on Brian Katz, who's the Vice President of Child and Youth Services at the Center for Child Development. Brian.
Thanks, James. Well, I guess it's good afternoon for everybody now, depending on where we are. So my name is Brian Katz. I am from the Center for Child Development in Surrey, BC. And I want to start today just with a couple of quotes that I thought were relevant. First is Sir Winston Churchill: if you're going through hell, keep going. We're about now 8 months into this, or 9 months. And I'm not sure any of us really particularly understood what the long-term impact would be. I think, you know, for a very long time, we were all in crisis mode. And I think, you know, many of us have now had to really start thinking about this as more of a long-term solution that we're going to need to slog through. The second quote is from BC's Provincial Health Officer, Dr. Bonnie Henry, who said, "We're all in the same storm, but we are not all in the same boat." And this is really gets to what I think Tracy was speaking to very eloquently earlier, and kind of where I wanted to begin, which is that while the COVID pandemic has certainly impacted all of us, it has not impacted all of us equally or in the same way, and all of our clients. So I'll start there talking a little bit about just looking at some of the population data. And I think, you know, to my point, so this is a graph of new daily reported COVID cases in Canada. So you can see the initial spike in the spring, then the lull during the summer, and now our most recent increase in the fall. And I think just to make a point, I pulled this data for end of October. You know, we're now 9 days into November, and if I pulled this again, you would see, you know, even a much larger increase. So we're looking at a situation that's really constantly in flux and constantly changing. Similarly, if we look at age distribution for COVID cases, and just to be clear, this is cases, not deaths. You know, we see here that it is our kind of 20 to 40-year-olds who are most impacted in terms of new cases. I think that's particularly relevant for us as service providers, since that is obviously the age of many of our parents. So it's important, I think, to, you know, not lose sight of the fact that those parent age people are pretty much the highest proportion of new cases that we're seeing here in Canada. And finally, just this is some preliminary data by Ed Gary and colleagues from the US, but they were looking at both incident rates and deaths in some large metropolitan areas in the States, breaking it down by ethnic diversity and also by poverty. And as you can see, there was certainly a you know, significant effect for those in terms of infection rates and deaths, in terms of, you know, if you look particularly at poverty being a very important predictor of new cases. So all that's to say is that really, you know, this impact is affecting, you know, many of our communities more significantly, particularly those with fewer resources. So as I mentioned, I'm from the Center for Child Development in Surrey, BC. We serve about 3,000 children a year with special needs, kind of a one-stop shop for children with special needs and their families. I've listed, some of the services that we offer here. So we have about 160 staff, and we've been around for about 53 years. So as we really engaged in this crisis, we had a couple of guiding questions that really helped us. The first is, what is the current situation? So I think that really stresses the importance of keeping current with the data from public health professionals and also the recommendations from public health professionals. We know those were kind of changing constantly over the months. And then particularly important for us as a charity was, how does this affect our ability to deliver on our mission and mandate? As a charity, that's really always first and foremost in our mind. So we had to look at things like, what modifications can be made to our service delivery model? Will services look different for different services? So, as an example, our speech language pathologists, making the transition to virtual care is, more straightforward in terms of providing their services over telehealth. Our physiotherapists, on the other hand, had a much more difficult time. Obviously, if you need to assess tone, for example, that's much more difficult when you can't physically put your hands on a child. So we really had this understanding that different parts of our services were going to look different. Also prioritizing the services, we had to make some adaptations to our prioritization criteria in the pandemic, realizing that the stress of it has been significant for some families, and that certain families may have to be prioritized. We typically prioritize our families based on, medical need, but we had to pay much more attention to the psychosocial stress that many of our families are experiencing. And finally, looking at balancing client need and staff safety. We understand that our staff have very different tolerance levels. Our clients have very different tolerance levels. So really trying to be flexible and creative in terms of coming up with a service delivery model that would, provide the maximum amount of safety for our clients and for our staff, while still delivering services as best we can. So kind of the heart of that was the development of these, what we'd call a COVID response plan. And that really was a very detailed plan to look at how staff work remotely, what resources they're able to access, under what conditions they can conduct in-person visits. And again, as I mentioned, really the importance of being flexible. And those protocols are constantly changing as the public health situation is changing. To pick up on Tracy's point earlier, identification, remediation of barriers to access, I think is incredibly important. Telehealth is great if you're a family of means and you have high-speed internet and you have equipment and all of that, and you have private space where you can meet with your staff. We know many of our families don't have one or even any of those things. So it's really, I think, important to ensure that that doesn't become a barrier. Language and cultural barriers can also be, exacerbated. It's hard enough for many of us who have English as a first language to figure out some of these technologies. With some of our families whose language is not the first, English is not their first language, it's even more difficult in that you're now trying to explain, Zoom or Teams or whatever platform you're using. And we know as well from the data that, previous stressors become exacerbated in times of crisis, and that for us has led to an increase in both child abuse and domestic violence reporting. We also really found it important to communicate with all of our stakeholders. There's a lot of information going around And it's important to have really clear and concise communication to try and let people know where we are through websites, social media, all staff meetings, all sorts of things. And then importantly, budget, right? I mean, we are probably different, similar to many charities, that we did not have a pandemic budget set aside for purchasing things like PPE and telehealth solutions, right? And so, from a budgetary standpoint, we had to all of a sudden, do a lot of scrambling to really come up with, with a budget for those things. And, we're relatively large, and that was probably a little easier for smaller charities. I think it's even more of a problem. So going forward, we're not in Kansas anymore. None of us are, and I think it's important to acknowledge that we're not going back to Kansas. We are in a new world, and in all likelihood, COVID-19 has permanently changed the way we do our jobs and we provide service to families. I really do feel like this does provide an opportunity as well. Our sector tends to be a very conservative one, and I think this crisis has really provided an opportunity for us to really move ahead and advance things that might have happened more slowly. So looking at some of the pre-COVID and post-COVID differences, I think working from home is something that we, historically thought of as more of a luxury. I think we now know that that's going to be part of the norm. And this was referred to already, but I think many of us had talked about virtual service as a kind of nice to have in the future. We'll get to it someday. Whereas now we had to get to it. So I think that's going to be, in the long term, a very significant benefit for the families we serve. Pandemics, I think many of us last year would have thought that was kind of a 19th century thing. I think now we know that there's not only this pandemic, but there's possibly more future ones to come. I think that's something that we need to plan much more for. Physical space, I think, for those of us in the sector, physical space is always at a premium. We always said, how can we find enough offices? And I think now with the increase in telehealth, we really need to look at being more creative with our physical spaces. How can we design them for telehealth? And how can we have more flexible workspace? And finally, looking at new ways to kind of remediate some of those barriers, right? In-person visits used to be a very powerful tool. We now need to be more creative in terms of accessing families who have limited access to technology to really ensure that we're not doing anything to increase the disparities in the health system that are already existing. So I think with that, I will turn it back to James. Thanks.
Thanks very much, Brian. And that idea of that concept you introduced of not going back, which I think we all agree with, I want to return to that into discussion. But first, I'm going to call on our final presenter, Alex Munter, President and Chief Executive Officer for the Children's Hospital of Eastern Ontario. Alex.
Thanks, and good afternoon, everyone, and hello from Ottawa. As I listen to Tracy and all of the other presenters talk about their experiences, I'm reminded why so many of us in the child and youth health sector fought so hard for the reopening of schools and child care and other services that create structure and create opportunity to support kids. And here at CHEO, one of the things we often say is that while children are among the least likely to get very sick from COVID, they have been the least infected, but they've been the most affected by COVID. And the public policy response that we need for that is really to recognize that the risk today is that not that kids' lives will be disrupted for a couple of years, but that the entire trajectory of children's lives could take a very negative turn if we don't get a response from government. And I would say the response from government has been mixed. And so we've seen, I think, a focus on schools and childcare in terms of the reopening that across all of Canada that has been important and welcome. not without its problems, but has been a priority. I would say the record's a bit more mixed on the response to kids' health and developmental needs. So here in Ontario, we have about 165,000 kids that are waiting longer than the clinically appropriate time for their health intervention. Now, keep in mind, of course, and people have given several examples through the course of this panel, that only includes the kids that have found their way onto a waiting list. So families that are affluent enough to be able to buy service, for example, aren't represented on those lists, nor are those that don't have access to be able to get on the list in the first place. But 165,000 kids waiting longer than is clinically appropriate. And we have, and this is good news, we have had government action on those that are on surgical backlog lists. And so there's been some investment to help us catch up on deferred surgeries. But we've had nothing yet in terms of developmental therapies and the backlog for mental health care. And here at CHEO, our longest wait times for surgery are 24 months, for developmental therapies are 18 months, and for our most specialized mental health services, which happens to be for kids with dual diagnosis, is 12 months. And as everybody here will understand, every day matters in the life of a child. And really, we all of us who care about this need to figure out a way we've all been trying, but to continue to figure out a way to put these issues front and center so that they do get traction and reaction and investment from government. So more work to be done there. In terms of the work locally here, just a word on our structure and response. The slide you have up has a CHEO bar across the bottom, but really our response has been characterized by the work of the Kids Come First, Les Enfants Avant Tout health team. Those of you from Ontario will know there's something called Ontario Health Teams. We've created a regional child and youth health team here, 60 partner organizations, 1,000 physicians, several thousand families involved. And it kind of created that partnership in 2019, and it was in place when the pandemic hit. And so it was a bit of an infrastructure that we could use to respond. And really, we were guided in our response by what we were hearing from families. And so we heard from many families, and Tracy spoke to that, the need for respite care, and whether that was, and so we had multiple programs, on-site respite here for kids with special needs, in-home respite, in-home nursing assessments for kids with medical and social complexity, emergency respite for family caregivers. So that became, for the Kids Come First health team, an important priority. We heard from families that many were unable to get access to immunization as family physician and pediatrician offices were closing. So we set up immunization clinics for routine baby and toddler immunizations. As all of you will know, immunization, of course, a point of connection to services and care. We tried to help address some of the issues Brian's raised around congregate care settings and making sure that they had PPE, making sure that they had training on infection prevention and control, and that was a major thrust of our activity. So 21 different initiatives, happy to talk about. Those are also all on our website. Really born of response to what we were hearing from families. And some of that was big issues around support for families. And some of it was really small in the moment, but big on that day. So for example, we heard a lot about the need to support and prioritize kids with sensory issues at our COVID testing center. So CHEO runs the swabbing center for COVID in Ottawa, and we've developed programming, support, training to help families through that process. So I would say the experience of the past 9 months has been that we have been able to pull together as a community to respond. We have been limited by our resources. We have been limited by the lack of priority on children in the current context, and the fact that we came into it with somewhat emaciated infrastructure to begin with in terms of the capacity that we had. At CHEO itself, we have, of course, like all organizations, pivoted towards virtual care. Whether that's our virtual emergency department, moving our mental health services online to be able to respond in that way. And in our autism program, really putting a focus on school readiness, sleep, caregiver resources. And just today, this is very timely, Jessica, just today announcing that the social ABCs, working with Holland Bloorview, the social ABCs now available through the CHEO autism program, thanks to the help and support and innovation of our friends at Holland Bloorview. So I'll wrap up there to say, I think lots to reflect on in terms of our ability as a community to respond, our motivation as a community to respond, and lots to think about in terms of the risks that all children, but in particular children with exceptionalities face in this coming period, and the need for us really as a sector to be able to unite and press the case with government for the kind of investment and support required to help these kids and families at this moment.
Thanks very much, Alex, and thank all of you for sharing your insights and your stories. So I'm going to follow along on a couple of themes that emerged from a lot of your presentations. I think we're actually probably universal. And Brian captured this, I think, with the comment, "We're not going back." We hear about getting through the pandemic, but the reality is the changes that have been forced on a lot of sectors, including ours, are not going to be reversed when we come out, even when we come out of this. It's likely that these types of online service delivery or blended models are going to continue. So given that, and particularly in the light of what we heard from Dr. Blackstock this morning about equity and accessibility, and actually that was raised here as well. And this is paraphrasing actually from one of the questions that came in, is how do we maintain and expand services online so that traditionally underserved families can have greater access to supports? And Chaya, you're nodding, so I'm going to start with you, because I'm sure this is an issue that's come up with several of your community partners.
Yeah, well, certainly in some of the communities that we're working, developmental support services for infants is something people haven't even heard of. So the fact that we're partnering and working to build capacity is actually bringing new services to communities that weren't there before. And whether it's through this kind of mechanism online or by phone, parents seem to be very thankful. And it's horrible that they even feel they have to be, but they're just so relieved to know that there is something out there. Like, I think about this foster mom with her 4 little kiddos, and now one of them has been kicked out of school, and I'm thinking, like, that would just be okay. And now there's a whole team that's come together to say this isn't okay. And this isn't an appropriate response from any school to provide. So I think that this pandemic has actually opened up opportunities, and I would probably say especially in remote areas or harder to serve or get to areas, we're seeing greater engagement with this kind of service being offered.
Okay. So Tracy, would you maybe comment on that? Because here, I mean, the concept that Chaya is talking about is increasing capacity within the community to support themselves because they know their community best. So is that an approach that we should be promoting?
Well, it's interesting. I was thinking about that, Chaya, as you said it. It brought to mind for me a whole series of thoughts about peer supports. And, you know, I know as a parent that sometimes the absolute best supports that I have are the other parents around me who have already tried something, done something, figured out what worked, figured out what didn't work. And so I do think there's an element that Alex was raising before about commitment to kids and where we are investing. But at a ground level, I think the idea of equipping communities to do more peer-to-peer supports and interventions has the ability to scale, perhaps much more effectively in the short term.
Anybody else like to comment on that? Back to you then, Chaya. So I want to, yes, go ahead.
Yeah, I just want to add one more thing, and I know we are all working with kids of varying ages, but I know I do think that young children, especially, and their families have paid this huge price. When the pandemic was at its peak, many, I won't say all because I don't know for sure, but there were many public health units in the province that stopped providing things like breastfeeding support, home visiting supports to families that we already knew were vulnerable. And I think as we get ready for the potential of another lockdown, I hope not, I hope there's a vaccine first, I hope we figured this out, Tracy, to support families like you in a more meaningful way, in a better way. I really hope we figured it out, because it can't just be we're redeploying staff and, oh, well, if that mom who's going home with a 3-day-old doesn't get support for breastfeeding, doesn't get a home visit, nobody's calling to see how she's doing, oh, well, that's the price that we pay. It just can't be the answer, you know? So I hope we do a better job for families like yours if we have to go through this again.
So I think we're going to continue to go through. Well, the children and their families are still going to have these issues, these problems, even on the other side of this. So we absolutely have to continue. How do we do a better job? And so, Alex, I'm going to come back to you because one of the questions that came up, and so I want to make sure I get this. So given all of this information and the things that we've heard, are there some overarching or universal concepts that we should be promoting moving into policy that will lead to better support for kids and families? Where should we be encouraging our decision makers to affect change?
How much time do we have? So, you know, a couple of things. I mean, I would reflect on the fact that here at CHEO we had a slow-moving digital health plan that all of a sudden, like I think we've heard lots of examples from every other organization on this panel as well, that, you know, within weeks we were doing stuff that would normally take us, you know, months of committee meetings to figure out. So I do think we want to be able to hold on to some of those gains. You know, recognize some of the issues around connectivity and access, although, you know, federal government announcement today to extend broadband access across the country into remote, into, you know, 98% of Canada. And I would say that, you know, that has been, it is not a solution for everybody. It's not a solution for all children at all times, but it has been a game changer in terms of the accessibility of care, the accessibility of information, and even even if I think about things like virtual rounding, solving problems that we've had for a long time. And so some intentional support from government to secure the gains in service delivery, I think will be important. But to draw an analogy, that there's a doctor in town here, not at Chia, who often you see news coverage that says, oh, this kind of vegetable or that kind of fruit is particularly healthy for you, and he always mocks that. He says, look, none of us are eating enough fruits and vegetables, so any fruit, any vegetable is good for you. So let's just stop talking about this one's better than that one. I feel a bit the same way about developmental services, in the sense that sure, we can have a conversation about what would be best from government. I think we're not there yet. I think we just need to get the attention of government. Almost any attention from government is an improvement over what we have now. And in the Ontario context, developmental services are siloed in the social services ministry. It's not even a health intervention. It's not about health outcomes. And historically, it's not a criticism of the current government. It's been this way for decades. The way in which the Ontario government has managed the demand for the escalating demand for developmental services with a frozen budget is to tighten and tighten and tighten eligibility. And so, I run an organization that's funded both by the health ministry and the social services ministry, and I see the difference. On the health side, the view of government is, and there aren't unlimited resources either, but on the health side, care goes to those who need it most. If it needs to be rationed, it goes to those who need it most. On the social services side, care goes and intervention goes to those who meet eligibility criteria and have been waiting longest. And so we get the kinds of scenarios that we've had the autism program, where children wait 5 years for a therapy that is most beneficial and they're 3. And so I think really cracking the nut on this and having a different perception and priority for developmental therapies and thinking of them as crucially needed health intervention, and thinking about the outcomes that they produce and assessing them on that basis, as opposed to kind of a social services eligibility framework. I think that's the single biggest win that we could achieve. That's an Ontario lens. Maybe it's a nirvana in other provinces, but certainly from an Ontario perspective, I think we've got a ways to go.
Well, that's a terrific idea. And since we have Brian, who's in BC, maybe Brian, same question to you, and maybe comment on what Alex has raised here. How would you advise your government on the best way forward?
Yeah, and BC certainly, we like to think of ourselves as nirvana, but not perfect. And I think Alex's point is very well taken, in that for example, our services are funded through the children's ministry and not the health ministry, and we here as well see significant disparities with how the health system is operating versus how the children's ministry and social services. And again, that's not specific to any one government or party. That's historically the way it's been for a very long time here as well. It did bring to mind to me kind of this concept of universal design that we talk about in the disability community, where we're looking at designing things not specifically for folks with disabilities, but that will be beneficial for all. And I think when we're looking at COVID responses and access, that's a useful lens to look through. As we talked about, there's for telehealth, for example, there's the issue of broadband access, there's the issue of technology, language, sociocultural, all of those things. So I think it's really incumbent to advocate for kind of a holistic approach to providing services during the pandemic that really acknowledges not only some of the barriers, I guess, that we've been discussing on this panel today, because one of the concerns that I really have is that that this has the potential to really increase disparities in the healthcare system that are already existing, and I think that would be an incredibly disappointing outcome if that was what were to happen. So I think it's really important to advocate for solutions that will equitably kind of raise the tide for all families, regardless of their situation, and really interventions that are consistent with our universal healthcare system, where we really say that there is a universal healthcare system for everybody here in Canada, and that should be the situation as well when we're looking at healthcare delivered in the time of COVID.
Yeah, thanks for that. And Jennifer Zwicker's made a comment that we're hearing so much incredibly valuable information. Our challenge, the challenge to all of us is how we're going to capture this and keep it moving forward. So Jessica, I've got several questions on requests for more information on the social ABCs, specifically how and where it can be accessed. And it was great to hear from Alex that it will now be available through CHEO. So, sorry, let me just make sure I've gotten this. More information on social ABCs that we can share with families. Is there a wait list for accessing, or how are parents being connected to this program?
So it is very exciting that CHEO is ready to go. We've been working with a number of groups across Ontario, but also across Canada, to get to move what we're doing in research into clinical care. So this is one of the first, so it's really exciting. There is rather than spending too much time on specifics, I will tell you, I do know that in Hamilton, it's also available through McMaster Children's Hospital. But we also do have a website, which is socialabcs.ca, where families and providers can go to get more information. But right now it's just on that cusp of becoming more available more widely clinically. But there are research opportunities as well in Ontario, in Edmonton, in Alberta, and also in Nova Scotia right now.
Yeah.
So
I just wanted to add just a thank you, since I have her here, is as you heard, and as all of us have had our hands full through the pandemic, trying to respond, and folks at Home Bloorview, Jessica and her team also had their hands full, but despite that, they worked really fast and really effectively to help us stand this up here in Ottawa. So we are very grateful to you for that, and thank you.
Well, thank you. Thanks for that, Alex. And I think I will reflect, specifically with you guys, but also with the teams that we've been working with, that flexibility and adaptability has been amazing. And we really have been able to train groups in very different ways, because every group that we've been working with has different rules and regulations and access to kids, or some of the training has been virtual, but also the practice has had to be virtual, and really amazing adaptability across the board. We're working with a couple of groups, a group in Israel now and a group in India also. So we've really been able to, really embrace the virtual platform that we were a little bit intimidated by. So we're excited that it's moving forward so quickly. And thanks to CHEO for being one of our first.
So Chai, I get the same question on Nurturing the Seed, whether there was a website where folks could go to get more information.
Yeah, so they can join our eBlast to get notified of trainings and stuff. A lot of training will be We've pivoted our whole training model, so it's all online now, and we've implemented a coaching model, and Nurturing the Seed will be one of those things. They can contact me directly if they're thinking, well, can we be a Nurturing the Seed site? Because we are still bringing on sites to the project. We have 3 or 4 new sites that are just going through the process of getting set up. And so we're happy to, and I think for us the most important thing is just there needs to be a local champion. You know, I would imagine, Jessica, you would agree that, you know, none of this stuff is going to happen if there isn't somebody local. It could even, you know, could be a parent, Tracy, like you, but there needs to be a champion who's going to say, this is really important and our community really needs this. And if you're the local champion, or you know someone who is, then please feel free to reach out to me directly at my email, and that's available at our website, imhpromotion.ca. And you can get some more information there as well.
So I'm going to go around the table with one. We might get a couple more questions in, but one going to ask for a short word blast here and see what comes out of it. So I'm going to say the best thing and the worst thing about moving to an online or virtual service delivery model. Jessica, you're first in my view, so I'm going to go to you first.
So I think I've sort of articulated the best. We really had hoped to go virtual in order to scale up access and sort of reach out to families who are perhaps harder to serve, a bit more remote. So that's the best. We've really been, we've had success, and we're feeling optimistic that we can keep building on that and reach more families more quickly, as well as more providers and more partners, and just keep growing exponentially that way. I think the hardest, and you know, I keep hearing from my coaching team who are so positive and so motivated and engaged, but you know, I do hear from some families where my coaches wish they could be in the homes like they used to be, for families who really need that one-to-one, that personal approach. So we still have one-to-one care, but feeling that in some cases the relationship building is a little bit harder virtually, and in some cases that the intimacy that can really help some families may be sacrificed more than we'd like it to be. So I think, further to the point that was raised at the very beginning of this panel, this can't be, virtual can be great and has lots of opportunities, but it can't be the only way moving forward.
Okay, Chaya, you're next in my line of sight, so I'll go to you next.
I think they're one and the same thing. Going online was great, and going online was terrible. It meant we could reach so many more people, and frankly, and James, you know that my schedule was horrendous before the pandemic, and I was on planes and trains almost every week, and it was crazy. But relationships are at the core of what we do. It's the core of our work with practitioners. It's the core of the work practitioners do with families, and it just takes longer online. It does. And I think there are families for whom this just does not work. There are kids for whom this does not work. If you can imagine trying to support a mom with a child who may or may not have special needs and is at home trying to breastfeed and has no support, and how do you do breastfeeding support virtually, you know, to a toddler who's got a language delay, or, you know, any number of issues. So I think the pandemic presented opportunities, but it made some things a lot harder. And we're going to have to really wrestle with that, because I'm ready to get back on a plane and go to a community and sit down with families and sit down with practitioners in the same room with them. And so even for me, as much as families, I think, miss it. I miss it too. I think we learn a lot more when we're in the room. I do.
Brian, I'm going to throw that question to you next.
Yeah, and I would really echo the relational part of it. I think for both for families and for service providers, the relational aspect of what we do is so important. And people go into this field because they like that relational piece and they want to do it. And I think the longer the pandemic goes on, the more difficult it is. And as we've talked about, really, there are certain families where that building that relationship online is either going to be much more difficult or impossible. So I think the loss of the relational aspect has really been the biggest challenge for us. I think in terms of the best thing, I think really virtual care came about because of the pandemic. So that has been a positive. I don't think it would have come along as quickly. And the other thing is really one of the things we talked a little bit earlier about peer-to-peer support. And one of the things we found is that for some families, this is actually a much better model of peer-to-peer support. When we're running our parent groups, it can be a challenge to get everybody to come in, particularly you have some families where parents are working, some families where parents aren't. So day versus night becomes an issue. And we just find that for a lot of families, the lack of having to, get up and drive, even if it's close, or arrange for different childcare, a lot of those barriers are actually reduced. And we've had really a lot of success with respect to our parent-to-parent peer support groups because of that. So that, I think, has been one of the positives.
Excellent, thanks. Alex.
Well, I mean, I think that's the paradox, right? Virtual care has knocked down a whole bunch of barriers to make care more accessible and to, not to sound too much like a CEO, but to increase throughput. But it's also entrenched some barriers and made access worse for some for whom it was already difficult. So I think, that's why, we had to go all in because of the circumstance. We've learned a lot, we've built capacity. And so now I think, having a more planful and intentional approach to digital health and virtual care delivery allows us to keep the barriers down where it does that, and to identify where it entrenches barriers and seek to remove them.
And Tracy, I'm going to give the last word to you.
Well, I mean, I want to echo everything that all four of you just said, because I think yes to everything you just said. I think that the other thing that we've realized, again, for our family is I don't want it to go back to being an either or an or. There are so much that having virtual online technology-based solutions helped us. It gave us access to resources that might have only been in person before and would have either geographically or for any other reason would have made them limited, that suddenly became available and were huge helps. And as I said, on the flip side, technology solutions in our case sometimes created more of a risk and relied on a relational connection that wasn't there yet. But the ability to be able to seamlessly move between the two of those as we all figure this out is what's ideal for us as a family.
Excellent, thanks very much. So you've heard a lot of information, a lot of ideas, great discussion. One thing that came through clearly is the need for all of us to continue to advocate on behalf of our kids and families. They don't get attention. They were put at the bottom of the list. Alex's point about healthcare being targeted to those who are in most need. Well, I think what our families discovered was they were at the bottom of the list. They were at the bottom of everybody's list, even if they were even on the list. So we can and should do better as a society. What you've heard, those of you in the audience, we've heard from a group of very dedicated individuals who are trying to affect that type of change and support it. And Tracy, we are indebted to you for sharing your story with us, which I think was an essential voice and to put all the rest of this discussion in context. I want to thank each and every one of you for giving us your time and your thoughts and your honesty in this panel this afternoon. I think you've given all of us an enormous amount to think about, but also some inspiration for how we can move forward together. So thank you very much. And I will turn it back to our host and moderator.
And thank you, James, Jessica, Chaya, Brian, Alex, and Tracy for that insightful panel discussion. And I want to thank the rest of today's speakers. I'm going to make a few reflective comments because I've been listening intently all day. It's been quite a fascinating and stimulating day. I want to begin with Dr. Cindy Blackstock, our keynote speaker who gave the Fraser Mustard lecture. There were so many points to reflect on, but the ones that stood out in my mind that she charged us to pay attention not just to the blatant colonialism, but evidence of invisible colonialism, examples that we don't notice even though they're present. We are focusing on a current pandemic of COVID-19. That was a running theme throughout the day, but First Nations people have experienced pandemics long before COVID that wiped out 90% of a population of 65 million, just staggering. Reconciliation does not mean I'm sorry. That might be a beginning, but it's certainly not the end. It means action to address the many socioeconomic determinants of health discrepancies that hamper the growth and development of First Nations kids today. An interesting thing that caught my ear, that the residential school experience was a perverse form of foster care. And Dr. Blackstock made the very cogent point that if you address those socioeconomic determinants of health, clean water, address poverty, address educational discrepancies, substance use, access to the internet, that the need for foster care evaporates. And one more thing that she said that certainly will drive me to be thinking differently about things that I've thought of before, that this is no time for incremental steps. Blackstock called for a giant leap. And that's a thought that will stick with me. Our first lightning round, led by Dr. Jill Zwicker and featuring research by emerging scientists Samantha, Christopher, Aaron, and Preeti, gave us quick but meaningful summaries of their research, and we want to encourage them to keep on going. Our afternoon panel, which you just heard on service delivery, provided a very stimulating and apt capper on day one. I think the running theme is that it is the astonishing development of virtual care, the good, the bad, but the thing that I've taken from this is just how much development has occurred on the virtual care and the virtual assessment file in such a short period of time. It truly is astonishing. James started us off with a stark recitation of what happened the moment the pandemic was declared, genuine anxiety among students, and then he deftly pivoted to kids with neurodevelopmental challenges, what they faced, and it made me think immediately of my own son, Alex, whose sleep-wake cycles were totally devastated by the lack of that school routine. He lost peer support. He was very, very fortunate to have tutors that allowed him to continue his education and graduate from high school. Tracy Moisen, facing a family crisis, one kid kicked out of school. It was a heartfelt story that we needed to hear. These kids that she has who have FASD, experiencing the typical things that I've seen in my own son: anxiety, sensory processing, intellectual